Thank you very much. It's a pleasure to be here. I've been in many reception rooms. As a matter of fact, I am a member of the Academy, and it was in this room that we actually had our, at least the inauguration of when we get inducted into the Academy many years ago. And this is it is true, this is quite the library here that we have in the Academy, and it is quite the place. One thing about New York I know is that we run up and down the street all the time, and you never look. If you look at some of the buildings and you look at them outside, the architecture is fascinating, and the places that we have in the city and the state are fascinating as well. It's an honor to talk to you today about the state of health in the great state of New York. And so some ask, how do you sum up the health of the state? And one could say, is it the low number of people who have diabetes, or is it the high number of people who exercise? Or perhaps it's the low number of cancers, or the high number of people living to 100 or more in the state. Recently we had I believe it was maybe last year, it always changes all the time, we had the oldest person I think in the entire world was here in New York. It was at 115. I remember hearing this on the news one day when I was driving. Perhaps it's the largest number of people who see doctors every year, or the opposite. Maybe it's actually the opposite, that doctor visits are down because people are healthy. But that's the kind of thing that we think about at the department, and that's the kind of things that we're working on every day. We work to keep people healthy, and so that they don't have to see their doctors. And health is truly a complex issue. We can gauge it in many different ways. We look at these all the time, but our goal is always the same: to make New Yorkers the healthiest people in the nation. And in New York, we always say, we're the best, and so why not be there and do exactly what we need to do to be at the front of everything for the United States. And too bad the Yankees or the Mets are not in the World Series, but they will be. They will be. There's a lot of talk about healthcare reform in the country. We've heard about it. It's moving extremely fast. In New York, we knew that the only path to true reform was to address how providers are paid, and that was a key part of what we were doing. And that's why the payment reform is needed to sustain the changes that are being made, and obviously through district delivery system reform incentive payment program. So we've been working on that for several years. We want to move from a fee-for-service system to one that is value-based and puts a premium on the quality of care. And these are major shifts. These are things that are completely different than it was 20, 30 years ago, and particularly I remember when I entered medicine. Our ultimate goal is to reduce avoidable hospital use, both inpatient and emergency room visits, by 25% in 5 years. I will say that I mentioned this to a lot of people. When I was an intern, I remember that if I did something and I didn't get a specific test and it was on a Friday, and I sit down with my senior resident and I say, well, I didn't do that test. He said, okay, well, why don't we just keep the kid here over the weekend, and then we'll get it on Monday. That would be unheard of today. First of all, it would never have happened, but it'd be unheard of to think that, well, we'll just keep him here for 2 more days, then on Monday, now that you realize you should have done that, we'll do it on Monday. But that's just a completely different way of how we practice medicine. The system will no longer reward doctors for sending patients for more tests, for more doctor visits. It will reward them for quality and for keeping your patient healthy and keeping them out of the hospital and providing the services they need. Healthcare professionals have started establishing value-based payment arrangements. Medicaid managed care plans have set up contracts with value-based payment contractors, which might be an ACO, IPA, or other groups of providers who come together to contract with the managed care plan. Contracts may be bundled by conditions, such as maternity care, or it might be for a specific subpopulation of patients who have special needs. And we see this all the time. There's specific patients who fall into a category, and you realize that there's a whole group of patients that we're trying to tackle their problems that are similar, but not exactly the same, but similar. They could also be integrated into primary care services. And already the performance provider systems have started to earn performance payments for hitting the metrics and the milestones that we've asked. And this is great preparation for the transition to value-based payments, which is clearly coming soon. District forces provides us to take a new approach to health, one that requires addressing, as we just heard a little bit about, the social determinants of health. And this was something which years ago we didn't talk about that much, but we realize that social determinants are critical to, if you're going to change healthcare, you're going to have to change some of these social issues. Once they enter a higher risk-based payment arrangement, providers and managed care plans will be required to work with other sectors of the community, such as housing, education, transportation, employment service, to build healthier arrangements and healthier neighborhoods that people have. And if the neighborhood's better, then clearly their health will be better as well. A community-based organization must be part of the requirement. Examples may include contracting with a soup kitchen or a meal delivery organization to provide meals to Medicaid members who can't leave their homes or are just unable to pay for them, or to prepare, obviously to pay for them, but also to prepare them. They may just have medical conditions that just make it just too difficult for them to do this, so we have to work with them on that. A lot of people say those who are living alone, they often don't even eat meals. They eat whatever is around because it's a lot different. You get lonely and you sort of feel like, well, I'll just grab whatever's in the cabinet. So we need to work with them. Our providers have the full support of the governor on this, who throughout his time in office has worked to improve the social determinants of health. And we know that social factors such as good jobs, safe housing, crime-free neighborhoods play a bigger role in health than our genetics, or our doctors. And so when you look at the numbers here, these social determinants are really important. Under Governor Cuomo's leadership, the state has increased the minimum wage so that people can afford better housing and more nutritious foods. We have enacted paid family leave so that New Yorkers can take time away from their job to care for loved ones without the fear of lost wages. And these policies aren't just economic. These policies are good for the health of all New Yorkers. The state has also funded more than 10,000 units of supportive housing created by the Regional Economic Development Councils to spur job growth and increase access to healthy foods for New Yorkers in need. Sometimes I see, even doctors who, in training, see them run out and grab food that's really not healthy for them. And say, well, it's fast and it's quick. And so we have to sort of get our young doctors to set better examples sometimes. We know that spending money on these social factors is less costly than paying for medical interventions that are done down the road. When people develop the chronic diseases from living from substandard housing, from not eating well, or not being able to exercise in their communities just because it's not safe to go out. So we've got to tackle that. We're now in the second year of DSRIP, and by 2019, which is the fifth year of DSRIP, all the Medicaid managed care plans must use value-based payment systems that reward value over volume for at least 80 to 90% of their provider payments. Both the state and CMS are committed to this transformation. I was talking to some of the leadership at CMS last week, and we were discussing this exact issue. In fact, it's a requirement under the MRT waiver amendment that funded DSRIP, so the PPSs across the state are working together to implement these DSRIP projects. And they're starting to understand what it means to operate under a pay-for-performance mentality. As of September 2016, the PPSs have earned 99.4% of all available payments. And of course, none of this means we should ignore healthcare per se. So, for example, the issues of breast cancer screening. So we have a major breast cancer screening initiative. Every one of us here knows somebody who has been affected by breast cancer, whether it's a friend, a relative, a colleague, and it is a horrible situation, and it's a horrible disease, and it is life-altering. And every year in New York, nearly 15,000 women are diagnosed with breast cancer, and 2,700 of them will die. So the governor is committed to this, and we are working hard to do everything we can to make sure that diagnoses are made early, interventions are quick. It's the second leading cause of cancer death, but women could do something about it, and they're getting screened, and they can have mammograms, and we are working to figure out how to remove some of the obstacles to that. Finding cancer at the early stages, as we know, increases your odds for survival. So, and that's where treatment's obviously the most effective. But a lot of times women won't get screened just because they're busy with jobs and childcare, and a lot falls on women. I know I see this with relatives and family members. A lot falls on women, taking care of elderly parents and taking care of their kids. And so sometimes they put themselves last, and that's a problem because an early mammogram, early test, getting screened is really important. So we have a Get Screened, No Excuses campaign. And we want to make it easier just to provide services and so to get appropriately diagnosed and treated for breast cancer quickly. So just this month, we enlisted 10 contractors around the state to deliver community-level peer education to women about the importance of breast cancer screening. If they need more information, they will also be discussing the importance of prostate screening for men. And we also enlisted 34 nationally accredited breast centers to host a patient navigation project. The trained navigators at these facilities will help underserved women navigate the healthcare system in order to get properly screened, diagnosed, and treated. And as one who, we all have been through the healthcare system, but I can tell you, as one who's been through the healthcare system, it is complex. And even if you know the system, and even if you are part of the system, you worked in it, and even if it's places that you're familiar with, still it is complex. And often what ends up happening is someone just says, you know what, it's too much, I give up. And we don't want that to happen, so particularly with issues of screening. So we're requiring hospitals and clinics to extend their hours for screening. You don't want to end up showing up somewhere and say, well, it closed. And that's hard because, so I say, well, I just took off part of the day, I ran up there, and now it's closed. So we're going to work to extend hours. We're delivering public service announcements on the importance of mammograms, and we're making changes to insurance laws so that the insurers in New York cannot impose cost sharing for mammograms or diagnostic tests. That means women at high risk for breast cancer will not be deterred from that test simply because of the cost. And New York's breast cancer screening initiative is the most aggressive in the nation. I've spoken to my colleagues elsewhere in the country, and they are impressed by what we're doing. We know how important it is to catch diseases early in the early stages, and we're also being very proactive in managing the state's opioid epidemic. The entire nation is at a war against these drugs, hydrocodone, oxycodone, codeine, to name a few. And what often starts as an attempt to control pain becomes a struggle to overcome addiction. And when prescriptions run dry, many addicts turn to heroin, a cheaper street alternative. And the consequences can truly be fatal. Deaths from opioids in New York have gone up 50% in the last 5 years, and New York fought back. Last spring, we convened a task force led by Lieutenant Governor Kathy Hochul and Arlene Gonzalez-Sanchez, who's the Commissioner of the Office of Alcohol and Substance Abuse Services. I served on that task force, and we went around the state. We spoke to a lot of individuals. You heard stories, actually moving, compelling stories of people whose relatives, whose friends got addicted to drugs, and the outcomes were very sad, very, very sad. It has ravaged communities. I look at the numbers. I've seen it in particular areas of the state. There are upticks, but all across the state and all across the country. So in June, we presented the governor with a set of recommendations to combat opioids. The result was a new law signed in June that lowers the limit for initial opioid prescriptions for acute pain for 30 days to no more than 7-day supply, with exceptions for chronic pain and other conditions. And truly, if you have pain, like if you think about it, it's after 7 days. If you're continuing to have pain, probably call your doctor. Find out what's going on. So I mean, giving someone a 30-day supply is not a good approach. And so I'm glad we switched to 7 days. The law also requires ongoing education for providers on addiction and pain management. It eliminates prior authorization so that patients can get immediate access to inpatient treatment for addiction and drug treatment medications. It will add more treatment beds and program slots for people seeking services for addiction. This is one of the toughest problems in the country. And it allows more trained professionals to administer naloxone or Narcan, which obviously reverses an overdose of opioids. But we need more help. We currently need more physicians to be certified to prescribe medication-assisted treatment, or MAT. It uses drugs like buprenorphine for opioid addiction. And new federal legislation will expand those who can prescribe this treatment to nurse practitioners and physician assistants. A lot of times, doctors, healthcare is changing. Nurse practitioners play a critical role. Physician assistants play a critical role. A lot of other people play a critical role in our health system today. People see their pharmacist more than they sometimes see their doctor. When you have to go in and get a prescription once a month renewed, you're going to be standing there in front of a pharmacist. Questions will be answered. You may not see the doctor for 3 months, 4 months, or 5 months. So we need to look and see who else is out there and how do we work with everyone who are providers of healthcare. We are calling on the feds to move quicker on this important issue of expansion so that more people can get life-saving treatment for addiction. This is something else which was brought up when we all met as group of health commissioners across the country a couple weeks ago to talk about this as well. And in fact, in this region, including just this past Monday, every fourth week, all of the state health commissioners for the entire northeastern area, from Maine all the way down to New Jersey, and all the states in between, all of us sit and talk for 1 hour every month on this exact issue. What are we doing? What are we doing across states? Because the borders, someone go right across borders. How do we work with our colleagues about this issue? And then we also talk with the federal agents and HHS and our teams down there. So every month, this is a 1 hour discussion. We meet usually on Monday mornings from 7, or on the phone 7:30 to 8 on issues in general, but once a month we spend 1 hour just on this issue. New York wants people addicted to opioids to get treatment and support they need so that they can move on with their lives. This is truly will change the course. It goes back to this issue we were talking about, social determinants. It goes back to this. Everything starts to switch. And then there's issues of jobs and housing and employment and all these other problems and nutrition and everything else that happens. So we need to get our arms around this. And the department's goal is to protect New Yorkers from the threats about this. And also, we are working on so many other issues, so I'm going to touch on some of the others. We also have a threat from outside our country, which is the issue of Zika. So New York has had the most expansive Zika testing program in the nation. As a result, and because of our incredibly diverse population, we have detected more travel-associated cases of Zika in the United States than anywhere else in the United States, and any other state or territory except for Puerto Rico, where they've had a lot of challenges with this, and we've spoken to them as well. We are equally aggressive in preventing Zika. We've handed out larvicide dunks. The governor had a 6-point plan that he put out there, and we've been pushing hard on this. We've gave pregnant women pregnancy kits that contain insect repellent, condoms, and information. We started this months ago. This was back in the winter, we started pushing on this. We asked local health departments for their Zika control plans, and they provided them to us. We launched a massive statewide education campaign to help travelers and pregnant women understand the threats of Zika. And New York has always been aggressive in dealing with diseases like Zika that threatens our well-being. And we can think about this when we were looking at the issue of Ebola. We were the first state to address this. We had an enormous meeting in the Javits Center before Ebola, even before that one case we had here in New York. And I think it was even before the case in Texas. But when we heard about it, to bring all the healthcare professionals in, all those who work in hospitals, everyone, the unions in together to talk about how are we going to tackle this. So we are always on the forefront of these issues, and we were with Zika, and we were with Legionella when there was an outbreak last summer in the Bronx, not this past summer, the summer before. That event resulted in the most aggressive regulations in the country to protect New Yorkers against Legionnaire's disease. They call on cooling tower owners to do routine tests for Legionella contamination, and for hospitals and nursing homes to test their potable water systems to make sure that there's not an infection there. And we recognize that Legionella is a fastidious little organism, and it's hard to control at times. Even when the threat to public health is not imminent, we are on the watch. And so this is an issue of antimicrobial resistance. So here's something which is happening. Right now, you can go to the doctor, you can get an antibiotic for pneumonia, you can get, if you have a urinary tract infection or any kind of bacterial infection, you get treated. But that may not always be the case. And the reason I say that is someday these antibiotics may not work. When I was at the WHO, I remember we were talking about this and said, there could come a time when there won't be an antibiotic that will treat an infection. So we are rapidly approaching that when infectious diseases cannot be treated because there's a resistance to all the antibiotics that are out there. And it's a little shocking when you think about that. These drugs have been used so widely and for so long that infectious organisms are out there, that antibiotics that are designed to kill have adapted themselves so that they basically will no longer be treated by that. And it's starting to happen. Each year in the United States, there are more than 2 million people infected with drug-resistant bacteria, and about 23,000 of those people will die as a result of those infections. And the threat was made worse relatively recently with something called the MCR1 gene. So the gene was detected in a Pennsylvania woman, and then we found it in a New York hospital. MCR1 makes bacteria resistant to all antibiotics. And New York decided to take the lead. We set up a New York State antimicrobial resistance task force. We're going to create partnerships working with others and new initiatives aimed at the prevention and the control of antimicrobial resistance in New York State. I remember I was talking to some relatives, and it's amazing that they were around, when we only had sulfur, and then we got penicillin, and this is in the lifetime of many people here in New York and around the country who are 80, 90 years old, and they remember there were only a few antibiotics, and then we had all these antibiotics. But when I was talking to them about this, they said, people worried that if you got an infection that you couldn't be treated with something, you could end up dying, and that was back, decades and decades ago. So we need to tackle this. We need to make sure we don't end up in a situation where there's antimicrobial resistance and we can't treat something. We want hospitals and nursing homes to adopt programs that improve antibiotic use and make sure that we're doing the right thing and that the drugs are used appropriately and only when they are necessary. And that's a really important issue as well. We want to take a collaborative approach across healthcare settings so all facilities share the same mission. And we're going to work with our partners in agriculture and education and other agencies to ensure that we have a unified front on this. I remember when I'll tell a little story about this, I'm sure you won't kill me. When I was in Washington, I worked for a cabinet official who had a cold. And he said, well, why don't you give me a prescription for antibiotic? And I said, no, this is just a cold, go home. It's like, but, I'm like your boss and top person here in the health department. And so you're telling me that you won't give me, I said, no, it's a cold. Just take some rest, some juice, get out of here and take a day off and relax. And he says, so, I could fire you. I said, you're right. And so I sat there and I put my hands like this. I said, Hippocratic Oath, job in Washington. Hippocratic Oath, job in Washington. Hippocratic Oath. And so I just go home. I said, I'll give you a prescription for something that you don't need. And then 2 days later, it's fine, it's better. And so we're gonna work with everyone. We're gonna work together on this. By the end of the year, we'll have recommendations for the governor on how to address this growing problem. And we recognize that this is what New York does best. Looks at a problem, looks at something, sees that it could be a problem, and then tackles it. I can go on and on about so many things the department's doing. We are touching 19 million lives, and we touch them in so many different ways, and we have such a great team. We have such a great team. We have a lab that does unbelievable things. We have offices that are working so hard, and I think that it's the dedication of everyone in the department that are working to make sure people's health is excellent in New York. But one thing is clear: we can't do all this or any of this without everyone in the room. We need the support of hospital administrators. We need all the healthcare providers, the nurse practitioners, the physician assistants, the doctors, the nurses, everyone, the pharmacists, occupational therapists, physical therapists, everyone. We need our elected officials. We need the local health departments, the business community, because as I mentioned, the social determinants involve all these different areas. We need education, agriculture, everyone out there. We need everyone to be part of the solution. So on behalf of the department, on behalf of Governor Cuomo, I want to say thank you. I thank you for all your support. I know that we will continue to move forward. We will help all of the millions of New Yorkers out there. We will do whatever we can to improve their health and their life. And I will tell you that there's not a day that I walk into the office that there isn't some issue, and that sometimes you just sit back and you realize that you're here to help people. And the other day I was with my nephew down in and he wanted to go to a restaurant in Greenwich Village. Kids 21, they always find some restaurant. So I'm standing there and I said to him, Andrew, I think I'm the oldest person in this area. It's 10:15 at night. You don't eat dinner at 10:15. And he says, yeah, you do. And he looked around and he goes, I think that guy's older than you. I said, thanks, Andrew. But then I looked at him and then I said to myself, these are all New Yorkers. These are the people that the department is here to take care of and to make sure that they're well and that they're healthy. And I said, and every day when I go into work, I realize that those are the 19 million, going on 20 million people in the state that we're here to help. And whatever I can do to help everyone, I will do. And if there's anything that you want to bring up, just feel free to email me, send me a note, and I'm glad to be there. So thank you very much.